Depending on where you are in the world, it's either morning or afternoon. Welcome to our association's final webinar of the year. Today's webinar is going to focus on the criminal justice system and expanding access to medication-assisted treatment through different parts of the justice system. We have two presenters today, Paul Samuels of the Legal Action Center and Brandy Harrison of the Allegheny County Department of Human Services in the Justice Collaborations Division. Both are going to talk about different experiences. Paul will talk about the breadth of policy development in this area, which has certainly accelerated over the years through state legislation, potential federal legislation, certainly working with federal agencies in this area. And Brandy's going to talk about the actual development of a treatment behind the walls, the first of its kind in the state of Pennsylvania. For those of you who were with us in Philadelphia, Pennsylvania at a recent conference, you may recall that both were plenary presenters and did really terrific presentations, which were extremely informative and well received. And before we begin, I just want to thank Mallinckrodt for their support throughout the years for our criminal justice policy areas, and especially in supporting our webinars. And final thanks goes to Angelina Budia, the coordinator of our webinars, and certainly someone who does incredible work for our association throughout the years, over 20 at this point. So to give you an idea about this, and this is expanding access to medication-assisted treatment in jails and prisons, as I said, if there are problems that you experience in joining this webinar, you're going to send an email to angelina.budia@atod.org, or you call 201-218-8030. The way we work the webinar is following the two presentations. Paul will be first, Brandy second, then we'll open it up for questions and answers. You can certainly send your questions in as you would like using the email address that's here, and then we will obviously respond to them. And so this goes until 2 o'clock this afternoon, and I'm very respectful of time. So with that, we will now open this up. And first, to give you an idea before I introduce Paul, so he begins, the work of the association has featured this particular topic for over 20 years. And we've been doing presentations on this topic, and I've written articles. The first one I wrote, interestingly, was over 25 years ago in American Jails magazine. And I was reporting then on the Rikers Island experience in New York City, one of the earliest behind-the-walls intervention in treating opioid use disorder with methadone. Keep in mind that at that time, methadone was the only medication used to treat opioid use. And now, subsequently, you have buprenorphine, and you also have various other medications which are used as withdrawal agents. And so at this point, it was interesting to me how difficult a challenge this was in increasing access to care behind the walls. Very typically, the view would be we're following the instructions of the court, we're keeping the inmates as long as the court has decreed, and we're providing the basic protections that we need to for the inmates. And then it has morphed over the years into, we now also see the value of treating these inmates, because what we've learned, and I'm sure that Brandy will report on this, but we've learned also in our experiences in New York, in Rhode Island, in Connecticut, and elsewhere, that as people are treated with either methadone or buprenorphine behind the walls, which is typically the case, or naltrexone, what you also find is that as the inmates are released with planning and are connected to community-based facilities upon release, there's been more than a 50% reduction in recidivism and more than a 50% reduction in post-release mortality. And as many people know, when inmates are released, the susceptibility to post-release mortality is extremely high. From our point of view, and we've said this over the past 25 years, this is really a very good policy. It saves money. It helps people with their opioid use disorder. It has impacts on the families and the communities. So we've encouraged this throughout the United States and through our affiliation with the World Federation for the Treatment of Opioid Dependence throughout the world. In fact, in some cases, other countries, Spain as an example, has implemented this experience in 100% of their correctional facilities in the entire country. Also in Europe, we have found major improvements in providing access to care. And this has been supported by the World Health Organization and other international organizations that are affiliated with the United Nations, like the Office of Alcohol and Drugs in Prisons in the UN. So with that, it's my pleasure to introduce Paul Samuels, the president and the executive director of the Legal Action Center, a friend and colleague for many years, a person of just tremendous knowledge and just a wonderful person. And so with that, Paul, I'm grateful that you could join us. It's now up to you.
Thank you very much, Mark. Appreciate it. We at Legal Action Center greatly appreciate our very long-standing partnership and collaboration with ATOD and with all the terrific providers around the country. It's really an honor and a privilege to be working with you and to be able to present today. Before I get started, I also want to state my thanks to Mallinckrodt and to the Fore Foundation for making possible the work the Legal Action Center is doing in much of this area. I want to start where Mark just left off, and that is to talk about how high the stakes are for our constituencies in dealing with substance use disorder in the criminal legal system, jails and prisons, as well as in community-based parts of the criminal legal system. And as Mark said, the mortality rates of people who are released from jail or prison without the kinds of services and treatment that they need is astronomical. Some studies find it as much as 129% increase in the risk of fatal overdose in just the first few weeks when people are released. So the stakes are very high. At the same time, the opportunities are enormous because, as Mark also said, the flip side is that when we do provide the kinds of healthcare, the kinds of services, including medications for the treatment of substance use disorder, for an opioid use disorder, people get better. They not only don't overdose, they become healthy. Crime rates go down, recidivism goes down. The benefits are enormous for everybody in the system. Money gets saved, lives get saved. So there's really great opportunity to try to make things better on this issue in our country. And we start from the proposition, and I know that ATOD does as well, that medications to treat substance use disorder and opioid use disorder should be available throughout the criminal legal system. That includes both induction onto medications once people have been assessed, and they need to be assessed. Everyone should be assessed for what their healthcare needs may be, whether they're incarcerated or under community supervision. And then they should be provided the services that they need. And that includes medications when that's appropriate. And that should be happening across the criminal legal system. On the one hand, we know it's not. But on the other hand, we know that there's been tremendous improvement in recent years, and we now have more and more models that demonstrate, as Mark was saying, just how effective these services are. And that makes the case that it should be universal. A couple of other core principles that we believe is that individuals in consultation with their clinicians, with their medical providers, should be able to choose the medication that's most appropriate for them, whether they're in the community or whether they're incarcerated or in the criminal legal system. Also, the criminal legal system should not force people to switch from one medication to the other without clinical justification. People should have that opportunity to decide with their treating provider what is best for them and be able to get that. And it shouldn't matter what facility they're in or where they are. Also, we strongly believe that people should not be disqualified from getting medication to treat substance use disorder, opioid disorder in the criminal legal system if they have a positive screen for illicit substances. We know that that goes on, that relapse is a part of the condition of having a substance use disorder. And just because someone is still suffering from that illness does not mean that they should be disqualified from the treatment that can help them get better and that indeed can save their lives. In addition to these principles from a health perspective, it is also now crystal clear in our country that a blanket denial of access to medications for the treatment of opioid use disorder and substance use disorder, including by the criminal legal system or healthcare agencies, is actually illegal. It violates the Americans with Disabilities Act. More than a decade ago, our attorneys at Legal Action Center analyzed this issue and came to the conclusion that just as if someone with diabetes was being denied the opportunity to have insulin or any other kind of illness where someone was being denied the gold standard, the appropriate medical care, that is illegal discrimination under the Americans with Disabilities Act and other disabilities laws. And we are really been greatly heartened now for through a decade that the Civil Rights Division of the United States Department of Justice, under several administrations, both Republican and Democrat, have come to the same conclusion that we did, that a blanket denial, refusing to allow people to get the medication that they need for their opioid use disorder is a violation of the law. And in fact, even better, the Justice Department Civil Rights Division not only came to that conclusion, but they have put their time, their resources, and their effort necessary to enforce that legal requirement. When I used to do this presentation earlier, I would go through a few cases that had been brought, but now, fortunately, there are a large number of them. So I'll give you just one example to show how the Justice Department has been ensuring the right to have access to medication-assisted treatment in the criminal legal system through a series of enforcement actions, including successful litigation. And the one that I'll highlight, because it had perhaps the greatest reach, is that the Justice Department brought suit against the Unified Judicial System of Pennsylvania, the entire court system of Pennsylvania. And the reason was that 11 courts, at least 11 courts in the state of Pennsylvania had restricted access to medication for opioid use disorder, not allowing people to be able to get the care that they needed. And typically that would take the form of someone coming in front of the judge on a criminal matter and the judge saying, you have a substance use disorder, you need treatment, I'll allow treatment instead of having to go to jail or prison, but on condition that you not have medication as part of your treatment. And as I said, we think that's a flat out discrimination against the person. The Justice Department reached that conclusion. They first issued a letter of findings that the court system in Pennsylvania had violated the ADA, the Americans with Disabilities Act, by prohibiting or restricting access to medications for opioid use disorder treatment. And then when the court system in Pennsylvania did not change their policy, the Justice Department actually filed a lawsuit against the Pennsylvania court system, at which point negotiations ensued and a settlement was reached in which the Pennsylvania court system agreed that they would stop this kind of discrimination. So that shows you with the really the leading civil rights power in the country, coming from the federal government, that these legal rights that people have to medications to treat opioid use disorder and other substance use disorder really matters. It has teeth, it's enforceable, and it needs to be obeyed. There are also real possibilities to leverage regulatory and legal and legislative reforms to strengthen the availability of medications for opioid use disorder in jails and prisons. I think all of you are probably aware of the new SAMHSA regulations governing opioid treatment programs that were recently promulgated. They have had a great impact in a positive direction. More people have entered treatment and stayed in treatment in the community as a result of the new regulations' greater flexibility. We also see real opportunity to utilize those regulations in order to expand the use of medications in jails and prisons. And there are several options that those regulations, we believe, offer that everyone can consider around the country. That prisons and jails can explore the feasibility of registering as a hospital or clinic to directly dispense methadone to patients. They can also review the potential of each facility to establish an on-site medication unit of an opioid treatment program to create a partnership with a community-based OTP to have them come in and provide the medications, which may in fact end up being the best solution in many, if not most cases. Also, to utilize the regulatory reforms to ensure that each jail and prison has the audiovisual technology necessary to conduct induction in cooperation with an OTP when an incarcerated person wants to begin methadone treatment, for example. So we think those are all opportunities now for our jails and prisons around the country to expand their use of medications and to partner with community-based programs, OTPs, and individual practitioners to make these life-saving services and medications widely available to everybody. There are also some important legislative victories that have been won that are coming into practice. One of them is that next year, all states will be, and counties will be required when someone comes into is incarcerated in a jail or prison, if they're on Medicaid, to have their Medicaid suspended rather than terminated. And I'm going to talk a lot more now about Medicaid because it is such a crucial funding stream, as we all know, to all of our services and especially to OTPs and medication assisted treatment. So a big problem if people get incarcerated and their Medicaid is terminated is that when they come out, it becomes very difficult for them to get the health care they need at the very moment, as Mark and I have both mentioned, when their lives are at greatest risk. So we have focused for many years now on expanding the availability of Medicaid for people. And I'm going to go through a number of ways to do that. And the first one is that if someone is on Medicaid when they're incarcerated, then rather than terminating their Medicaid so that the person would have to go through the whole enrollment process all over again when they're released from jail or prison, that we have long argued and urged jails and prisons to suspend that Medicaid rather than terminate it so that it can be turned back on when the person comes out. And in fact, there is actually advantages. There are also advantages for the jails and prisons, because if someone is on Medicaid when they're incarcerated, although the law right now is that Medicaid cannot be used inside the walls, and I'll talk a little bit more about that in a couple minutes. If someone has to leave the jail or prison to go into a facility such as a hospital or other kinds of inpatient overnight care in the community, then Medicaid actually can pay for that, even though the person is otherwise incarcerated. So that can actually be a significant cost savings for states and localities if people's Medicaid is maintained while they're incarcerated. And as I mentioned, though, fortunately, the law was passed that goes into effect next year that will require the suspension rather than the termination of Medicaid when someone is incarcerated. And that hopefully should lead to many more people having the coverage that they need to be able to have their health care, including these services, paid for. We also urge states and localities in their jails and prisons to enroll people in Medicaid when they're incarcerated if they're not already on the rolls, because that is legal also and has the same kinds of advantages that I just talked about for when it comes to not terminating people who come in with Medicaid. So enroll those who are not on Medicaid when incarcerated, and suspend rather than terminate for those who come in with Medicaid. And that it will also be important logistically when the person is released to make sure that their full Medicaid is turned on, even if they're enrolled. The computer systems have to be adjusted to make sure that when they go in for care, that their healthcare provider will actually be able to access the Medicaid, and also making sure that the individual has a Medicaid card. So that when they go to a facility, they'll be able to demonstrate right away that their Medicaid eligibility. Now, another aspect of Medicaid that creates real opportunities for our population is a new initiative called Medicaid Reentry. And this is something that we at Legal Action Center pioneered with the New York State Department of Health over a decade ago. And it addresses the issue that I briefly mentioned a little while ago, that under the law, Medicaid cannot pay for healthcare services within the walls. That has been the case since the beginning of the Medicaid program. And it creates the problem I talked about, which is that if there's no Medicaid coverage, then often people get no services inside, or at least inadequate services inside, because the healthcare providers inside, whether that's the staff of a jail or prison or outside healthcare providers who come inside, cannot get reimbursed by Medicaid for those services. So the new initiative, the new Medicaid Reentry Initiative, allows states to get a waiver from the federal government to do a demonstration project to utilize Medicaid inside the walls for up to 90 days before someone is released. And that would enable Medicaid to cover an assessment, a diagnosis, a treatment plan for those who need medications, and not just medications to treat substance use disorder, but also psychotropic or other kinds of medications. They would be able to be inducted onto those medications, paid for by Medicaid. And then discharge planning services, connectivity when the person is released to community-based services so that there's a warm handoff and seamless treatment. All of those services could be paid for by Medicaid. And these waivers are issued by the Federal Centers for Medicare and Medicaid Services, CMS. And it allows for payment of certain time-limited transitional healthcare services. And as we know, as we've talked about, preventing overdose is so critical. And it's really exciting that right now 19 states have received these approved Medicaid reentry waivers and are working to implement their demonstrations. And another 7 states have applications pending. So that's more than half the country. And it's really important to emphasize that this is a nonpartisan, really non-political approach. When you look at the list of which states have the Medicaid reentry waivers, it runs the gamut of blue states, purple states, red states, and it creates opportunities really across the country. It's important that those Medicaid reentry waivers move forward. There's also special requirements now for all states to provide certain Medicaid funded services to young people. So that is another positive another positive way of going forward to pay for these services. We also see a lot of benefit for these Medicaid reentry waivers to kind of pave the way for all kinds of issues that will arise in the Medicaid program as states learn how to enroll people, as we've talked about, keep people enrolled, link people to care as they come out. So why am I emphasizing Medicaid so much? Well, most, if not all of you, are probably aware of the answer to that. And that is that Medicaid is the largest payer of substance use disorder services in the country. It provides about 40% of all the funding for substance use disorder care. In 2022, the latest date we have figures for, over 15 million Medicaid enrollees, which was about 21% of the total number of Medicaid enrollees, 1 in 5, had a diagnosed substance use disorder. So you can look at it both ways. Medicaid is the largest funder of substance use disorder services, and substance use disorder is one of the largest sources of healthcare issues for the Medicaid population. So what happens to Medicaid is extremely important. You're probably all aware that HR 1, the One Big Beautiful Act, makes major changes to Medicaid. And given the potential impact on our field, and especially for people within the criminal legal system, I wanted to take the remainder of my few minutes to take you through some of the key issues that this new law will raise. So a place to start is that the law has been passed, and a number of cuts are coming, but most of the Medicaid changes are not yet in effect. However, we're starting to see some impact in anticipation of the cuts, and most importantly, states are already starting to prepare. It's not only opportunity, but there's really a great urgency for all of us to be aware of what's in this law, what the potential opportunities are to try to restrict the negative impact it might have, and to maximize the benefits. Also, that there will be a lot of variation in states. So work can be done by each of you in your states to try to impact how this law is implemented. And there is time, and I really want to emphasize that there is time to advocate for maximum enrollment of our population who are eligible. So just very briefly, what the law contains is it cuts approximately $1 trillion from Medicaid over the next 10 years. About a third of that, an estimate $326 billion over 10 years, is attributed to coverage losses resulting from work requirements. And how those work requirements are implemented, again, there's a lot of flexibility potentially in the states. And I'm going to focus just really on the work requirement issue, because that's the one that we think will potentially have the biggest impact on our population. So the work requirements go into effect on January 1st, 2027. So not this coming year, but the following year. Though at the same time, that's not a lot of time for states to set up, figure out how to implement, and then begin to implement a new system. And what the rules will be for the work requirements is that the Medicaid expansion population, those are low-income adults without dependents, the people who were not eligible for Medicaid before the passage of the Affordable Care Act, but became eligible. That's why it's called the Medicaid expansion with the passage of the ACA. So that population are, again, low-income adults without dependents, ages 19 to 64. And the requirements are that they must verify at least every 6 months as part of their application or renewal for Medicaid that they are engaged in work. And that work requirement, it's actually specifically is 80 hours a month of work, education, training, and/or community service. And that must be demonstrated at least every 6 months. There are, however, exemptions. And those are going to become particularly important for our population, both because there may be some people unable to work who will need to claim those exemptions, but also because the logistics, the red tape, the bureaucracy, whatever you want to call it, of having to demonstrate that compliance might be so onerous that if someone also can claim an exemption, it might actually be easier to do that. So let me take you briefly through what our recommendations are for addressing this. And the first, as I've been emphasizing, is that we're going to, and I'll take you through them in a minute, emphasize what the exemptions are and how our populations can benefit from them, and also ways in which we can urge the states to make those exemptions as broad as possible as are allowed under the law. And then secondly is to minimize the burdens of demonstrating either compliance with the work requirements or eligibility for the exemptions. And at the same time, prioritizing privacy and dignity and minimizing costs to the states. So first, maximizing exemptions. So there are two main sets of exemptions that to these work requirements that are particularly relevant to our constituency. One is called individuals who are medically frail or otherwise have a special medical need. So that's their terminology, not mine. Medically frail or otherwise has special medical needs. That includes someone who's blind or disabled. Also, anyone with a substance use disorder. Come back to that, of course, in a minute. Anyone with a disabling mental disorder, anyone with a physical, intellectual, or developmental disability that significantly impairs their ability to perform one or more activities of daily living, and anyone with a serious or complex medical condition. There is also an exemption for an individual who has participated in a drug or alcohol addiction treatment and rehabilitation program, although that is limited just to FQHCs and to nonprofit treatment programs. And then there is also an exemption for people who are incarcerated or formerly incarcerated within the previous 3 months. So to go back to what we think is the most important of these for our constituency, they're all important, but that's the exemption for someone with a substance use disorder, because that's the broadest one. Language that we and other advocates ensured it was included in this legislation. So it's the clear intent of Congress again, and this has broad bipartisan support for people with substance use disorder to be able to be eligible for Medicaid, whether they're able to work or not. And what we will be urging states to do is to maximize the breadth of that exemption by including anyone, not only anyone with a substance use disorder or has had one in the past, because we know that substance use disorder can be a chronic condition. People can be in long-term recovery, and many people are, but everybody should be able to get health care coverage if and when they need it. And then, so then the other major thing that we will focus on is to make it as easy as possible for someone to demonstrate their eligibility for these exemptions. And when you think about that, the range is incredibly broad. On the worst end of it, if somebody is going to have to constantly provide a diagnosis or other evidence of substance use disorder, that can be difficult, and especially for people who are not yet in treatment, who could be in the catch-22, whether if they're required to have a diagnosis, then they would need to go to a provider to get that diagnosis. But how can they get care if they don't have coverage, if they don't have Medicaid? So we want to avoid that kind of catch-22. So our recommendations are that states should make the process of demonstrating eligibility as easy as possible, including data matching where that's possible, maintaining privacy of treatment records, but linking up data that demonstrates someone's eligibility with the Medicaid office so that they automatically know and the individual doesn't have to do anything themselves to try to track down the required paperwork or other kinds of proof. Because we know from the experience in Arkansas and Georgia, which implemented work requirements, that the bureaucratic problems can really knock most everybody out, even those who are eligible either because they're working or because they're exempt. Another approach that we urge states to allow would be to allow someone to self-attest that they have a substance use disorder rather than having to provide actual proof of that, again, in the form of paper or otherwise. There's a lot of precedent for people being able to self-attest in these situations, including in Medicaid, in obtaining Medicaid. So I know that that's a lot to run through. There's a lot of opportunities. There's a lot of risks. And when it comes to Medicaid, the key is going to be to make sure that everybody who's eligible one way or the other can stay on Medicaid so that we can maintain and keep the future financial stability of the system, even as we try to take advantage also of the other opportunities that have emerged in recent years. So thanks very much again for the opportunity to speak, and back over to you, Mark. Thanks.
Paul, I appreciate that. As always, a clear and comprehensive presentation. Before I introduce Brandy, I just want to highlight some of what Paul just said because it's critical. The first is the importance of that Reentry Act. And our board of directors was in Washington, D.C. this past September, and we completely, in our 85 Hill visits, stressed the importance of passing this Reentry Act. The lead champion is Congressman Paul Tonko of New York, and the fact that it would do a lot of what Paul was talking about. I'm also encouraged with the fact that 19 states have projects which are now and waivers so that Medicaid coverage can be provided to inmates, and 7 states are pending. Obviously, I know that the questions are coming up. We're going to hold the questions to the end, and I know the questions have been coming in. But in this particular case, the importance of this cannot be underestimated. Also, keep in mind there are 3 basic approaches in how inmates in jails and prisons can be treated with medication-assisted treatment for opiate use disorder. One is that the jail or prison opens up their own treatment center. And I know Brandy's going to get into this during her discussion. There's another way through mobile vans. And the SAMHSA regulations, which Paul alluded to, allowed for telehealth services. Once telehealth services were implemented, and these regulations went into full effect in October of 2024, mobile vans started increasing in their number. And according to SAMHSA, there are 71 operating mobile vans in the country. A number of these vans are being used by the OTPs to actually go and induct inmates with methadone and or buprenorphine in the jail or prison setting, and also in making sure that patients continue as inmates to get access to these medications. And then the third is that OTPs generally work with jails or prisons to deliver medication to either the jail or prison site. And again, when you're doing these things, you need a TRITARC approval of SAMHSA, the Drug Enforcement Administration, and typically the state authority. In some cases in the states, you need Department of Corrections as well. But it is a tripartite arrangement at the very least. So with that, it gives you, now we're going from that broad overview that Paul presented now to the distillation of how a program opened. Again, the first of its kind in Pennsylvania. And now we'll turn to Brandy Harrison. Brandy, as I said, did a great presentation at our conference in Philadelphia. She's the project manager for Justice Collaboration in the Allegheny County Department of Human Services. So Brandy, now it's up to you.
Thanks. Get my slides started here. There we go. Okay. So thank you so much, Mark. And I just want to thank you for the invitation to share this information today. It is such an important topic. And the jails are really what I consider to be the missing link in our opioid crisis. As you see, some of these jails might be the folks, for folks that are on the call today. We've been providing evidence-based treatment for opioid use disorder for quite a while now, and we have quite a few evidence-based tools in our tool belt. But jails are where somebody who has been doing really well in treatment could end up in a situation in which they have no access to their medications for opioid use disorder and can quickly destabilize and become one of the most at risk for fatal overdose. And all that takes is being arrested and being booked into a jail. These local correctional facilities are really the missing link. They're where people are falling through the cracks. Many jails are trying to increase access to medications for opioid use disorder within their walls, but they can't do it without the help of treatment providers, policymakers, state and government authorities, peers, and advocates. And so first, I just want to share a little bit about like the scope of like how many people this impacts. You can see some statistics from the Bureau of Justice Statistics on the slide here, but a couple things just to highlight. Like 7.6 million people were admitted to local jails in 2023. Millions of people. And if you look down to the last point there, an average of 32 days in custody before release. So very short period of time, but definitely long enough to become destabilized. So that's why it's so important that we're looking at continuity of care when folks are hitting our jails. Why is continuity of care so important? Because research has also confirmed that overdose is the leading cause of death among people recently released from prisons, as well as the third leading cause of death of deaths in custody in U.S. jails. If you have a robust MOUD program in your jail, you're likely screening much better at intake, having a very thorough screening at intake, and you're catching those folks who may be at risk of death in custody as well. We find that a lot of those substance use deaths are happening. At this same study that found that it was the third leading cause of death, also found that the median time to death was 1 day. So 50% of people died who died from substance use, had substance use as a cause of death in U.S. jails, died within the first 24 hours that they were there. So having an MOUD program can also help you reduce those deaths inside the jail. And Paul referenced this earlier. People who've been incarcerated are approximately 100 times more likely to die by overdose in the first 2 weeks after they're released than the general public. And you'll see, I think 129% is the number he said. That's like the most commonly heard number that you'll hear. But you'll see some other studies that are done in different localities that might be higher or lower. But in general, they're all over 100 times. And if this is the first time you're hearing this, it may seem shocking. 100 times, that seems really high, but I'm going to talk through a couple examples here to show you, to help you understand how that risk escalates. So this first example is Joe. Joe has been stable on methadone treatment in the community for 3 years. He was just arrested on some very minor charges and booked into a jail that only offers continuation of buprenorphine. So when that happens, if someone's on methadone and they go to a jail that doesn't offer methadone, often they have to detox from the methadone when they come in. And a lot of times that's with minimal comfort meds. 8 days. 8 days later, um, he is released on a Saturday afternoon with instructions to return to his home clinic. Of course, his home clinic's not going to be open until Monday morning. And so here we go. We have someone who's been really stable on methadone treatment. He's in the jail for 8 days. He's been taken off of his treatment, detoxed, and released without any treatment until Monday. Who thinks that he's at a heightened risk of overdose? I sure do. We took a stable individual off of his treatment and released him with no supports for 2 days. If he goes and uses right now, he is at extremely high risk of overdose. If methadone continuation was offered at this jail, he could have continued his treatment and been released with the 2 take-home bottles to get him to the next clinic day and not had to experience that trauma of withdrawal. And his risk of overdose post-release would have been much, much less. Okay, our next person is Will. Will in the community is not engaged in any substance use treatment, but at jail intake, he's screened as severe for having opioid use disorder. He has had 3 documented overdoses in the past year. He was arrested for having drugs in his possession and booked into a jail that only offers medications for opioid use disorder to pregnant individuals. So he was also required to withdraw from substances. 3 times during his 6-month incarceration, he receives a misconduct. That's what happens when someone violates the rules in the jail. They receive what's called a misconduct because he was trying to get substances from other incarcerated individuals to address his cravings because he's still going through withdrawals. And then 6 months later, he's released, and they did give him Narcan upon release. So Will hasn't been in treatment before, so his risk shouldn't be any higher, right? Wrong. Because he's essentially has had a period of forced abstinence for 6 months, his tolerance is likely much lower than it was prior to his incarceration. If he leaves jail and uses the same amount he was accustomed to prior to incarceration, it's extremely likely to result in an overdose. He was given Narcan at release, which is a good thing, and that should always be happening. But imagine if he was able to be connected to medication for opioid use disorder during his 6 months in jail and begin a period of stability. We never want people to have to go to jail to get connected to treatment. But in cases like these, we should make the best of the time we have with them to make that connection and engage them while we can. So now let's look at an example where MOUD is available in the jail. So this is Becky. Becky has been stable on buprenorphine for the past 8 months. She was arrested for a retail theft and booked into a jail that offers continuation and induction of buprenorphine. As soon as she was seen in intake, she saw an addiction provider and was continued on her dose of buprenorphine while she was incarcerated. She was referred to a certified recovery peer specialist while in jail. When she was released 27 days later, she was released with that peer support, continuing post-release, including a connection back to a community clinic. So do we think Becky's risk of overdose has increased? We can't say for sure, as we don't have a lot of data yet, but probably not. What we do know is that her trauma's been reduced. Her recovery is more supported, both in jail and upon release. She has a warm connection back to her community provider and peer support to assist with any reentry and recovery needs. Compared with Joe and Will, I would say this is definitely more in line with setting a patient up for success and supporting continuity of care. So it's really, it's just a stark difference in how someone is treated. To drive this home a little bit further, In a 2024 survey of jails, less than half the jails offered medications for opioid use disorder to at least some individuals. So if you remember the second scenario, Bill or Will, they were only offering it to pregnant individuals. That's very common in jails. Like, it's very common that MOUD is only offered to pregnant individuals, and they'll transport those individuals off site to get the treatment, because that's usually a typically very small population. But if only 43% of jails are offering MOUD, and that's including those jails that are only offering it to pregnant individuals, we have a real problem. Think about that number that we saw before. Millions of people are being impacted by this. And then in the same study, only 12.8% offered medications to anyone with an opioid use disorder who requested them. And that 12.8% might only have one medication. They might not have all three, but they're offering it for both induction and continuation. So there really is a need to get get medications for opioid use disorders in our jails. This is a study that was just recently published. In Massachusetts has in recent years required that their jails have medications for opioid use disorder available to people incarcerated. And so the National Institutes of Health funded a study to see outcomes. And they recently published this and found that there was a 52% lower risk of fatal opioid overdose, 24% lower risk of non-fatal overdose, 56% lower risk of death from any cause, and 12% lower risk of reincarceration after release. And they were also much more likely to continue treatment. I mean, that is just staggering. If there was any other treatment that we could offer that would have this kind of impact, people would be jumping on it. But sometimes, because this is a medication, the stigma impacted, we have to get past that first. So I hope those examples, along with the information I shared about jail and overdose risk, made an impact, because it really takes everybody to make change in their communities. I'm going to briefly talk through 3 actions that you can take when you return to your community. And you can, no matter what your role is, you can help make this a visible issue. You can help move this work forward in your community. So the first step is really identify what's happening in your community. If you don't know if your jail is offering MOUD, and if they are, what medications and who's eligible to receive it. If you don't know what your fatal overdose rate is in your community, and how many of them were recently incarcerated, those are great places to start. In Allegheny County, Pennsylvania, that's where I'm from, between 2016 and 2020, we found that 19% of our fatal overdoses in the county were individuals who'd been released from jail in the year prior to their death. So that's about 1 in 5 of our overdoses. And half of those deaths, it's actually a little more than half, I think it's 53% of those deaths occurred in the first 90 days after jail release. That's huge, right? So when we were really advocating for these programs, we're like, this is a big portion of the people who are dying in our community. Like, we need to have this program to save lives. And you can't do that without knowing what's happening in your community. Actionable step number 2, identify your partners and collaborate. Jails can't do this alone. Opioid treatment providers can't do this alone, because you got to have access to the individuals who are incarcerated. You also need people who can access leadership and funding, and pull people together. You want to have people with lived experience at the table. So you really just have to identify the folks in your community and who who need to be at the table, and bring them together so you have a shared understanding of the current status and start setting those goals. And actionable step number 3, you want to vision big and then start smallish and build from there. So when you start, don't just think about like, oh, well, we can do this one little thing right now. Really start and think like if the magic wand, right? Like if I had a magic wand and we had like the perfect MOUD program in our jail, what would that look like? And then work backwards from there to think like, what can we do now? How do we get to this other part? And like, give yourself a roadmap. You want to set a timeline for long and short-term goals. That timeline will be adjusted, I promise you, like, because all kinds of things happen and some of those things are outside of your control. But it's really important to have a timeline to keep yourself accountable and keep moving forward. Identify needed resources. A lot of times people think of resources as money. It's not just money. You got to think about expertise, physical space, staffing, and even access to medication. Pharmacies sometimes have to request additional allocations, and we found that was one area that we didn't know about, prior to us going through this work. Workflow, writing out workflows, policies and procedures. And one thing I would definitely highlight is from the very beginning, think about collecting your data. Think about what you want to track, what you want to show, and how you're going to collect it, who's going to collect it, and where it's going to be kept. You got to keep in mind, one size doesn't fit all, but you can be innovative. There's a lot of room for innovation in this area, but you also don't need to reinvent the wheel. Really helping jails provide treatment to those incarcerated results in better outcomes for your community. It's good public health, it's good public safety. No matter what your role is, you can keep this work visible and move this work forward in your community. I'm going to dive a little bit into our experience in Allegheny County so you can see. This is just a little bit about Allegheny County. We're Pittsburgh, the home to the city of Pittsburgh, population around 1.2 million. This really was a very collaborative relationship between Allegheny County Jail and the Allegheny County Department of Human Services, where I sit. The key to our success was really leveraging project management resources and community agency relationships from the Department of Human Services, together with the jail's leadership's willingness to change and the hard work of that on the ground healthcare and operations staff. We have a strong and proud community advocate and community in our community, and they really helped keep this issue in focus as a priority as we moved forward throughout our timeline. And you can see from our timeline, this didn't happen overnight. We had a very intentional phased project. So pregnant individuals were receiving MOUD as early as 2016, maybe a little bit earlier than that. Vivitrol came on board in 2017 as a part of a grant opportunity. Almost all of these projects up until methadone induction they were all launched with a grant and then sustained past that once the grant ended. In 2020, we began oral buprenorphine continuation only. We started with a very tiny, narrow eligibility criteria and then expanded out as we worked through the kinks and the capacity. In 2021, we added injectable buprenorphine. 2022 methadone continuation. 2023 we started doing induction in buprenorphine, and that's when our numbers really skyrocketed. In 2025, I'm proud to say we were the first licensed medication unit in Pennsylvania, and we launched methadone induction in March of this year. And so the medication unit is the model that Paul referenced earlier. It's a licensed unit that is basically a satellite of a community OTP. So the Allegheny County Department of Human Services issued a request for proposals to our community for a provider to come in and provide methadone services 7 days a week, 365 days a year inside our jail. And we contracted with a community provider who came in, and we worked together with the jail. It required moving some stuff around. It took a little bit of time to do that, but we were able to stand up a medication unit within the jail that is licensed. We had both DEA walkthroughs and DDAP, which is our state opioid treatment authority here in Pennsylvania, a walkthrough for licensing to verify everything. But now we have all forms of FDA-approved medications for opioid use disorder available for both a continuation and induction in our jail. And we're starting to see the impact. If you remember the numbers I told you from 2016 to 2020 and those fatal overdoses, in 2024, which is when we started buprenorphine induction in late 23. So 2024 was early into the buprenorphine induction. We didn't have methadone induction yet, but we had all the continuation on board. That 19% of fatal overdoses had dropped to 17%, which is a small change, but it had started to trend downward. But what was really significant was that 90-day amount, that 90 days post-release had dropped to 29% of those deaths when it had been like 53% prior. So we are seeing a much smaller amount of people who are losing their lives in this first 90 days post-release. We also have peer support available to anybody on MOUD in our jail that follows them for at least 90 days post-release, which is helping support that as well. We have a public dashboard that's available for anybody to view in our community, or I mean, for you could view as well. This is just a screenshot from a month or two ago. On this particular day, there were 467 individuals in our jail receiving MOUD, and on that day, that was 22% of our population. And you can see it's broken down into to demographics, so it could be broken down into all of that. We also can see treatment trends. We can see who was receiving, there are different screens on the dashboard that shows us who was receiving MOUD in the community before and how many of them were continued in our jail. We can see how many people continued after they left the jail, filled through publicly funded claims. We can see who filled prescriptions, who attended substance use treatment appointments, mental health treatment appointments. And then for while they're in the jail, we can see how long it took them to be inducted, how long it took them to be connected to continuation, and what types of medication they're taking. So lots of things that we can track on our dashboard, and that's available for the public to see so they can really see the impact that this program is having. It's out there for anyone. And then I'm also excited to share with you a publication that came out in August that tells the story of our MOUD journey in the Allegheny County Jail for barriers to breakthroughs. And it really tells like the human story of like how we went through this and addressed some of the challenges that came up for us. And both of the dashboard and the narrative report are found at this QR code. I can also drop the link in the chat on the Zoom page as well. And so I'll leave you, I'll wrap up with a quote I've heard many times associated with recovery: don't wait for the change, be the change. Your community needs you to like make this a visible need and to keep this visible in your community and help move this forward. And so thank you for being here today, and thank you for caring about this. It's really important.
And Brandy, I appreciate that. Also an excellent and very clear presentation. There are a couple of points that Brandy made, and I'm just going to highlight them as I did following Paul's presentation. One, and don't let this be put aside, as Brandy indicated, if these successes could be attributed in other courses of medical care and medical treatment, there'd be a groundwell of support. So we have to advocate for these people. We have to advocate for the opportunity to provide treatment. And at a purely practical level, it helps the individual, it helps the community, it helps the correctional facility, and it restores and maintains life. And this is a very important concept. There is no loss as a result of this. Second point, and I encourage you, because I've said this throughout my career, keep track of the data. Brandy is quite right that basically all of the research that's been done over the course of the last 50 to 60 years is drawn upon to support why we do this treatment. And we need data because we can't only tell the personal stories, which are also important because it is a matter of human interest, but also the matter is you have to be able to convince people through data, whether the data include this is the success, these are the cost savings, these are the number of people in treatment, and these are the people who benefited from this intervention. All of this has to be captured clearly and in a persuasive way as part of our advocacy. So there are a number of questions that have come in during these presentations. The first one will go to Paul. So I'm reading from the question, our state director in the Department of Corrections has been instructed by his medical staff that they cannot use methadone in the prison setting. What laws should I refer him to so they can clarify what they can do in using methadone in the state prison system?
So thank you for that question, a really important question. And the answer is the Americans with Disabilities Act. The Americans with Disabilities Act is the major disability civil rights law in our country. Anybody who has a physical or mental disability as defined under the law, and substance use disorder is a disability under the law, cannot be discriminated against in healthcare in this way. That's the law that the Justice Department Civil Rights Division, the United States Department of Justice Civil Rights Division, has used, among others, to bring actions against jails and prisons just like that. We have resources available, including lists of cases. Mark, I don't know, however, we would be easiest to make those available to people, or people can, email us and we can send materials, but it's the Americans with Disabilities Act. There may also be, depending on the state, there may also be state laws that parallel the ADA.
Thank you. And Brandy, there's a question for you now. One of the challenges that we're having is a technical infrastructure. How do you get these data, and where does it come from? Is it basically electronic health records?
Yes, so we do pull in at the Department of Human Services, where we've worked to pull in the information from the jail's electronic health record, so we can match it with claims records from the publicly funded health claims, and then we're able to kind of pull all that together to provide its aggregate information on the data dashboard.
And this is going to be a question for both of you. Here's the question. We see the most critical issue with individuals who are utilizing MOUD while incarcerated being released to recovering housing residence or treatment facility, and then being denied entry because they're utilizing MOUD. Any thoughts on getting everyone on the same page with this? The stigma seems to be in the community for us. So you can either take a shot at that. Paul, let's start with you and
Sure.
then Brandy.
Sure. So it is definitely stigma, and it's also discrimination. The same law that applies to the jails and prisons applies to community-based providers as well, be they treatment programs, nursing homes, any kind of healthcare facility, any kind of program in the criminal legal system, probation or whatever. It's a violation of the ADA, the Americans with Disabilities Act, not to allow people to be on this life-saving medication.
Agree. And over the past several years, the Department of Human Services has worked really hard to educate and to make sure that providers understand that. And whether that's our residential housing providers or treatment providers. And it is a requirement of all of our contracted providers that they're not able, they can't discriminate based on that, like they're required to serve someone regardless of their status on MOUD. So.
And Brandy, this is a question for you as well. So for professionals like me involved in programming and designing correctional facilities, can you elaborate on the kinds of spaces that are needed to accommodate this kind of treatment program? Is there an operational preference for having dedicated MAT housing units within a jail? And how should these units be in size, the optimal number of beds, dormitory versus single cells, feel and look?
Yeah, I think it's less about what the number of beds and the, like, whether it's dormitory, and more about like where you might be able, what you want those units to have is to have space for individual and group treatment, right? Because that's where we have struggled, is like on our housing units in our jail, we don't have a lot of private spaces to have individual and group treatment. So sometimes people have to be transitioned off the jail to somewhere else. So I think that's really what you want to look at. Most importantly is that you have that privacy for folks to have those treatment options provided right there in the setting. We do find it very helpful to co-locate people on MOUD. It helps reduce diversion, and it also helps with the actual medication passing. We have a pretty large facility. Our average daily population right now is just under 2,000. So having folks co-located really helps that go much more smoothly. For the medication unit, I will say we did have to move some, there is like some operational space required for that, because you have to have a dedicated room that has very specific security and alarming alarms and cameras on it. Even though you're in a secure facility, you still have to have all those DEA requirements on the dispensary room. So that's definitely, if you're looking at the medication unit format like that, that's something to look at as well, space.
Okay, thank you, Brandy. And for Paul, so the question is, if someone in SUD treatment finds employment, does that jeopardize future access to the SUD exemption that you spoke about?
I assume that means in the Medicaid context. That's also a really terrific question. I can't give a 100% answer right now because we haven't received guidance yet from the official guidance from the federal government about what the rules will be, and then also states will be designing their own rules. But having said that, our analysis is we think that if somebody has an exemption, then the work requirement is no longer in play. And so it wouldn't work the other way. It wouldn't knock them out of the exemption if they're working. That's the positive view we have. with the caveat that until we see exactly what kind of guidance comes from the federal government and what states do, we can't be sure. But what I would also add is that it would really be terrific for all of us in our states to be weighing in with the state officials who will be designing these programs and raising that very kind of scenario and saying that someone with an exemption, our read of the law is that that's it, and you don't proceed to having to deal with a work requirement whether the person's working or not.
Okay, thank you. Very helpful. So Brandy, back to you. Based on your presentation on the Allegheny County Jail, is this initiative being carried over to the Department of Corrections in Pennsylvania as well? And specifically, are the prisons continuing this kind of treatment that is provided in the jails?
So the Department of Corrections in Pennsylvania, all of our state prisons provide buprenorphine, and I believe there are a couple facilities that provide methadone. So when we know that we're having somebody transition to a state sentence, everybody that's going into a state facility from the county goes into like this assessment center before they go to an actual facility. And we send all of their health records and their health information. But if they are on methadone in our facility, our addiction providers will have a conversation with them about transitioning to buprenorphine before they go, if we have enough time to, if we have enough notice that they're going, so that they can be continued on buprenorphine there. If we don't have enough notice and they're going, then we just make sure that they know at the assessment center that they're on methadone and that they need to transition to buprenorphine. But we prefer to like kind of do that before they go if possible. That way they can go and be continued right away.
Great. Thank you, Brandy. Paul, going back to you, given that federal law and the Department of Justice guidance already affirm the right to access all three forms of MOUD in correctional settings, yet many jails still restrict methadone and buprenorphine. Do you believe that further litigation is the only remaining path to ensure compliance, or are there other effective mechanisms to drive statewide adoption and enforcement?
Yeah, so another terrific question. So the way we look at this is that we need to be moving on a number of fronts at once. Yes, we do think that litigation is going to continue to be necessary. It's already had a lot of benefits in both creating legal precedents, making clear that denial of MOUD, of medication-assisted treatment, is illegal, and also demonstrating models for that. But we also think that there's a lot of opportunity to work with jail and prison officials, using the kinds of arguments that we've made today that Brandy outlined successfully has happened where she has been, that litigation, is something that, can be a hammer over somebody's head. It can be an incentive for some people, but so can all the benefits that come from providing treatment. The reduction in overdose death, the reduction in recidivism and crime, the improvement in healthcare, saving funding for the states and localities. So, we think the combination of those approaches has gotten us pretty far, but can get us a lot further.
Okay, and now we go back to Brandy. In your judgment, how should a new SOR coordinator reach out to a county jail and prison to begin the conversation in moving to the use of MOUD program or becoming an outright OTP?
Yeah, I think just reaching out, finding out who the healthcare administrator is in the facility, and setting up a conversation to just talk about what substance use services are currently available in the facility and what challenges they're facing, I think is like a great initial conversation. And then really taking it as like, how can we support you in getting better, evidence-based services into the facility to support individuals and reduce harm. I know our Deputy Warden of Healthcare Services has reported that since we have all of the medications on board for both continuation and induction, that they've seen a reduction in behavioral incidents on those pods. Like they've seen like positive things happening inside the jail as well. So I think like there's benefits there as well in communicating those and coming at it from like a supportive, like how can we support you in this work is really, really important.
Okay, thank you. And next one is for Paul. Our jail is denying individuals methadone induction because they previously diverted buprenorphine or other non-methadone medications. Which federal or state laws protect their right to receive MOUD, and does this practice violate the ADA or other federal regulations?
That's a good question. So, the basic principle is that people are entitled to get the kind of health care that they need. If there has been misconduct involved with the treatment, candidly, that can get complicated. It would be hard to evaluate how that might come out without knowing exactly the circumstances of what happened. But what I could say would be that, sort of to throw it back to the clinicians, that there may well be ways, if someone has been caught diverting, to ensure that they can't do that while still receiving the medication they need. And that's what I would explore. But I'm now out of my depth in terms of how you do that, and would kick that back to Brandy and Mark to comment on whether that makes any sense.
Brandy?
Yeah, I was gonna say, when our program first started, the leadership at the time did want people who had diverted to be removed from the program, and we felt pretty strongly that that shouldn't happen. Over time, we've been able to like reverse that, and now if we have folks who are diverting, they are like kind of re-educated by the addiction specialist first. If it continues to happen, they're offered an injectable, or they're offered a transition to methadone, because methadone is much harder to divert in the correctional setting because you're watching the person take it in front of you as a liquid. So I would just really say that, like, I think that if the clinician should really have that final say, because it's a healthcare decision. And if the clinician is saying that this person needs this treatment, then in my opinion, and I'm not an attorney, but it would be covered under the ADA, and we should be doing it. So.
Okay, thank you. And then I think one last question for you, Brandy. Can you comment on how the Allegheny County Jail works the Pennsylvania Department of Corrections to ensure a warm handoff for the inmates who've transferred from the jail to serve a prison sentence? And so that comes out of Alabama.
Yeah, so that's what I was talking about a little bit before. As long as we have a little bit of notice that somebody's transferring to state for a prison sentence, we work to get them transitioned to buprenorphine, because we know that the state will continue them on buprenorphine. And then when they're transitioned to that assessment center, we'll make sure all their records are going with them so that they can be continued. And then typically a phone call will be made as well to make sure that any questions can be answered, and that somebody is given a heads up that this person, and that like a doc to doc or nurse to nurse can be offered, so they can talk through that person's treatment plan. But yeah, we just try to do our best in making sure that we can get folks transitioned best as possible. We also have people going to other counties around us for court often, and sometimes they're just going for a couple of weeks, and those jails might not have any MAT. And so sometimes we are giving folks an injectable before they go, so they're covered while they're gone until they get back. So we're just really trying to be creative and making sure that people are covered when they have to go to another facility, whether it's short-term or long-term. Do the best that we can to make sure their care can be continued.
Great. Okay. So a question that came in, and I will deal with this, which is there a list of facilities in the United States that provide methadone and buprenorphine inductions? So I will work on that. Those lists have been published in the past. Obviously, they've changed, especially as I began this webinar with the fact that there has been expanded interest in providing access to medication-assisted treatment in both jails and prisons in this country. And yes, it's been a long, long process. And for anyone's interested, I can certainly provide a copy of the article that was published in American Jails Magazine 25 years ago. But as both Brandy and Paul have alluded to, there's been a lot of new information out there. Also, there have been many more opportunities for corrections to expand access to care as well. So in wrapping up, I just want to say that I'm grateful for your participation in this. I know it takes an hour and a half out of your schedules, and certainly to Paul and Brandy for presenting this extremely useful information. Angelina will be sharing this, both the PowerPoint that Brandy had and the information that's been alluded to in these two presentations. Also to Mallinckrodt, again, for their support in dealing with this correctional facility and criminal justice projects as well, and certainly to Angelina for coordinating this as she does with all of our webinars. So again, I continue to be grateful for the support that we have in these policy initiatives. As both speakers have indicated, is a very important part of our policy development. And our association lists this in our 5-year planning ventures as one of the key sort of policy interventions that we deal with. And because these are hard climbs, and this is complex and it involves people being educated, dealing with folks, as both Paul and Brandy have alluded to, this is never ending. And I can tell you in my 50-year career, where I started and where I am now, the issue of education, providing clarity, not only at the federal policy level or legislative level, but at state levels, this issue is no exclusion. It takes time and effort, it takes thought, and you have to have a plan. And both of our speakers have alluded to this. So I want to encourage you, share this information with people. Angelina will get it to you for sure. But the whole point of sharing this information is to encourage you in the treatment system. Don't take anything for granted and never feel a sense of defeat. There's always this as a possibility. And we do this because we advocate for the people that need care. That is our role, is to provide access to care. And that's because we know best. And that's why we do this stuff. So that's why you see a combination of both the law and the clinical care and the organizational policy. All of these are inextricably wrapped together. So I again thank you for your attention to this, and I hope this was helpful to you. Do please complete the survey that's coming out to you on request, because this is how we plan for future webinars. It does take time and effort. So once again, you get this survey at the end of the webinar. We'll give you notification about when the PowerPoint and the recording becomes available. If you want a certificate of attendance, that can be issued on request, and you see that to info@atod.org. So thanks again, and let us continue and enjoy the holidays to come. So thanks very much. I appreciate your involvement. Be well.